each of the measures look like, and when you're supposed to assess them and kind of why. So just some brief background. I worked with ISKI in 2020 to help come up with these implementation outcomes. We did it as a team. Essentially, they actually, if you can go to the next slide, one more. So the plan obviously is for all EHE or ending the HIV epidemic programs to measure a lot of these implementation measures because we have evidence-based clinical practices that should end the HIV epidemic, but unfortunately they haven't. So the goal now is to implement these things more effectively so that we actually can prevent people from becoming HIV positive. And for those who are HIV positive, we can get their viral load down and keep them healthier and happy for a longer period of time. Next slide. You could just keep going. Sorry, I had a bunch of these that had sort of slowed down. But effectively here, we're sort of, the whole point of these grants is to support high quality implementation science. So you have a grant for either 1 or 2 years, and I think most of you got 1 year and it's extending to the second. Where you are trying to implement something that we know works, but we're using a strategy, an implementation strategy to make that happen more effectively. And we also want to create more generalizable knowledge based on local knowledge. So let's just imagine that your strategy to implement something was audit and feedback. We want to see how well that works. Sorry, I'm adding people in.
Yawn when I can.
If you don't mind muting yourself, that would be great.
Yeah.
Thank you. And so, yeah, so the goal is to both to support you to do high level implementation science research, but also to learn from that what you're doing to help other people across the country to implement their projects more effectively and for health departments to implement HIV programming more effectively as well. Next slide. So this is the team that created ISKI or was sort of leading ISKI in 2020. And next slide. And Sophia, do you mind muting yourself?
Oh, of course. Yeah,
Thanks.
sorry about that.
No worries. Okay, so for outcomes for implementation science, as you have probably learned already, they're substantially different than what we sort of learn in your traditional epidemiology classroom. So this is what we sort of wanted to go through to understand what are the outcomes that the EHE program is looking at. Next slide. All right, so the implementation outcomes that we are going to look at kind of come from 2 places. As Proctor said in 2011, or what she published in 2011, is that we really want to have purposeful or deliberate actions to implement these evidence-based practices. And you may say, like, well, what is a deliberate and purposeful action? And effectively, that could be any kind of strategy. It could be educating a healthcare provider to do something. It could be task shifting from a clinician to a healthcare worker, like a community health worker. It could be audit and feedback. It can be a number of different types of strategies, but effectively something deliberate and purposeful to implement an evidence-based practice. Now, why do we need this? Well, we want to reach more people so that we have some success and we get people maybe who traditionally have not received the evidence-based practice so that we can determine sort of a proximal indicator of success. So whether the process is working, are facilities adopting an evidence-based practice? Are they delivering it with fidelity? And then get some clinical outcomes and service system outcomes as well to see if whether what you're implementing is showing some effectiveness. Next slide. So where does this come from? Kind of a combination of REAIM, which was Glasgow and colleagues from 23 years ago, maybe, and some outcomes from Proctor et al. So REAIM, most of you probably know, is reach, effectiveness, adoption, implementation, and maintenance. And then what they've done is they've added some of Proctor's outcomes, particularly acceptability, appropriateness, and feasibility into the mix in terms of things that you guys are being asked to assess. Next slide. So this is actually pretty important. A lot of times people get a little bit hung up on who they're supposed to ask some of these questions of and sort of what's the level of analysis. So just to give you a sense of these, is it 9 items that you're going to be asked to look at. So reach is at the level of the patient or the individual patient to see, are you reaching the people that you're hoping to capture? The theoretical basis is from the REAIM measure. Acceptability is again at the individual level, but it's at the level of the provider. So it's not, if you sort of think about how you're going to measure acceptability and even appropriateness, it's at the individual level, but also you could measure something at an organizational level or potentially policy. Feasibility, it's the same. Adoption, usually it's measured at an organization level, sometimes at the individual provider level to see if they're adopting an evidence-based practice and they are implementing it. Again, this is a REA measure. Fidelity is usually at the level of the individual provider, and fidelity is often synonymous with implementation. Cost is at the level of, I would say typically it's the organization or policy. I suppose it could be at the level of the individual. I don't see that typically done. It's also part of REAIM and also part of implementation. And then penetration. Oh, you can interrupt me at any time. If you have a question, just unmute. And I love the fact that that did not come through on my computer screen. So the question was, when would we like questions? So Russell, if you want to go ahead and ask, I am all ears.
Yeah, I'm also not a fan of Teams. Yeah, so I've kind of been using reach and penetration interchangeably. So just wanted to get your feedback on that.
So reach is typically at the level of the patient. So are you reaching, so in some of my work, we think, are we reaching patients who live in really rural areas, people who may not have legal status in the country where we're working? Whereas penetration is actually more at the organization or policy level. So if, let's just imagine that you did, you were trying to do a study on PrEP, and you wanted PrEP to be delivered to anybody who sort of screened positive for a particular, you had like sort of a screening tool to see who sort of needed PrEP. And maybe one of your strategies was having a community health worker do some counseling with that person, or maybe that community health worker did the screening. Your penetration would be how well did that strategy actually get integrated into the organization. So if that was your project, you take your money because your money is going to end after a year and you write up your paper. Well, is the organization actually going to have they written that into documents to say that this is actually something that the organization wants to continue? Has it become sort of normalized? And you may say, well, then, Carolyn, how is it different from sustainability? And often the better the penetration, the better the sustainability. So there is some overlap there, but sustainability, well, kind of talk about, you can also look at sustainability at the patient level and at the organization level. That penetration really is like, how well did that strategy or intervention become integrated into the facility or the organization? Does that make sense?
That helps. I also thought sustainability had like a time frame, maybe after 6 months or something like that.
Yeah, so at least 6 months. Some people would say you should look at it at 12 months. Yeah, whereas penetration, again, you would also have to say, like, at a certain point in time, has this strategy that I proposed been integrated? And you would set that on the front end, that I would imagine this would be would have good penetration by the time, I don't know, 6 months in or 12 months in, and you could set that on the front end.
Sounds good. Thank you.
Absolutely. Any other questions before I go to the next slide? Yes, I see a hand.
I'm trying to find everything. I'm a Zoom girl, and I can't find all the things. This
You are
is-
not alone.
This is going to be recording. I have like a whole lot of people from my group that are trying to get on and haven't been able to get on. So I will let them know that this is being recorded
Yeah.
and that the recording will be made available very soon, right?
Yes, we will post it on our site. Hina, I don't know, the next day. It will be soon.
Yeah. Thank you very much.
All right. So next slide, April. Okay, so this is where we are in the implementation research logic model. A lot of you are working on sort of determinants to understand why something may or not be working. So those are sort of the qualitative interviews that a lot of people do on the front end to understand sort of what are some of the intervention characteristics that may or may not be appropriate for your population. What are some characteristics in the inner setting that you might be able to leverage to make something more effective, or maybe a barrier, sort of so on and so forth. But what we're talking about today is sort of the outcomes, which is in that red oval egg shape, where we're trying to figure out sort of what are the implementation outcomes that you want to look at, or whether you want to look at them or not, that EHE funding is asking you to look at and then report to them at the end of your project. And Sarah, I saw you unmuted.
Oh, that was an accident. Sorry.
No worries. All right, next slide. We all hate teams. All right. So the foundation for all of this, as I mentioned, was really RE-AIM and Proctor's outcomes. It's been used for more than 20 years. And essentially what the team had decided was, look, we're going to look at all the RE-AIM indicators, add some of Proctor's outcomes as well. And what they did is they created really an Excel file to sort of help you guide when to measure different outcomes at different points in your study, depending on whether you're doing sort of a preliminary look at something, whether you're piloting something, or whether you're doing sort of a long-term sustainability study. Next slide. So their initial draft, I wasn't part of this group, but they organized sort of each of these RE-AIM constructs and tried to kind of tie outcomes to 8 different HIV interventions. So rapid ART start or PrEP, for example. They wanted to figure out like, well, what are the things we need to measure? When do we need to measure them? And how do we sort of what's the right word? Strongly encourage people to do so that we get some standardized data from all of these projects so that if everybody's measuring, let's just imagine acceptability in the same way, we can determine, well, hey, does this measure of acceptability work? Or did everybody have to make tweaks to it in order to make it useful? So in that case, maybe we need to come up with something new to do in the future. Next slide. So they had a big coordination process where they did a ton of work, a lot of meetings back and forth, where essentially, and I think this was mostly led by Dennis Lee, lots of meetings with the CDC, had these expert consultations where we actually looked at all of these different measures that they proposed, and we had to say whether we thought something was essential, it was, fine, not bad, or totally not necessary at different phases and projects. It was all ranked, and then basically created this template for everybody to look at. And I think it's useful. I hope it's useful. There are definitely still moments where people will argue, hey, this component says it's recommended, but I think I don't really need it, or this here says it's required, but for this reason I don't need it. There is still some back and forth. It's a living document. But I think it gives you a starting point to figure out what measures that you should have and sort of when you should start looking at assessing them. Next slide. This is just the group of people who are on the panel. Next slide. Okay, so I would say, and probably if you all put up your hands to get a sense of where people were in the stages of research, implementation research, most people that I have been working with are either in that kind of context, you're trying to understand the context to implementation, or you're sort of in that strategy selection or pilot testing of the strategy. Now, this makes total sense because you only have a limited amount of money. There's not too many people who are going to be doing a sustainability trial with a limited amount of funds. But because of that, it sort of impacts the type of data that you need to collect, and then sort of narrows down, I guess, sort of the types of data you need to collect and what you need to do with it. But I'll still go through all of the different sort of Excel files so that you can sort of see what things that you should look at measuring both now and then in the future where you decide to take your project to scale, or you want to look at something like a sustainability hybrid type 3 trial. Next slide. So this is what we had to do, where we looked at like the acceptability of the intervention pre-implementation, and then they put in like a rating whether something was required or recommended, and then we had to either agree or disagree. And if we disagreed, we had to give like a little document about why we disagreed with that. Next slide. There was generally consensus among most people, as I mentioned, but obviously there's going to be some disagreement. And so if you do have a difference of opinion, it's not going to hurt anyone's feelings. You just sort of have to justify why that is. Typically at this point, we have pre-implementation measures that are considered either required or recommended. Measures that are either required or recommended in the piloting or trialing, and then additional or different measures when you're taking something to scale. Next slide. And one more. Okay, so show of hands, if you know how to do hands on Teams, how many of you guys have seen this so far in your work? How many of you guys have had sort of access to a spreadsheet that looks like this? All right, we got one. April, you don't count. I know Sophia has. Yep. All right. So we've only got 2. All right. Well, if you haven't seen it, this is super important. And maybe Hina or April, you could actually throw it in the chat, the actual document, or I'll do it by the end. So you can download sort of essentially the spreadsheet off the ISKI website. But here's sort of how it looks. Remember, we're using the REAIM measure to sort of assess each of these different components. And we want to look at in the implementation preparation phase, or the piloting phase, or the bringing to scale phase, what are the things that we want to look at and how are we going to standardize that? So if you remember with REACH is a patient level metric where we are looking at who are the individual patients or clients that we're able to reach, and does implementing a different strategy allow us to reach more people? Because that should be the goal. We want to reach more people who we historically haven't been able to reach. So now if you're doing an implementation preparation stage, so you're not actually implementing anything, you haven't picked a strategy, you're not doing anything, you're trying to figure out how to do the thing, you can skip REACH because you don't need to measure it. So good for you, buoy for you. You just sort of say, Carolyn, I don't need to report any of this because it's not applicable. However, as soon as you start piloting anything, ideally, you're going to look at certain things that are required here. So if you look here, this is required, the number of potential patients across sites that are eligible for that intervention. That can be really tricky to actually assess. I will say sometimes the study denominator is the most difficult metric that anybody has ever asked me to collect, because if you are looking, let's just say, to implement PrEP across an entire city, figuring out how many people are actually eligible for PrEP could be really difficult. So you do the best that you can on some of these measures. But ideally, that's your denominator, right? Because you want to get to 100% here. You want to have all the people who are eligible are also the people who are offered the intervention and also the people who initiate it. Yes, Anne.
So we have a study, poor April has to listen in on our meetings, where we have individuals in a jail. Our previous data showed that 4% of individuals are HIV infected, and we have a health services team that is saying that they're too busy to do testing for HIV. So we believe that we can calculate what 4% of the population is, and we are trying to get individuals who are eligible for the intervention seen, but we are being referred only drips and drabs of patients. We know that not everybody who's infected is being seen by the HIV provider, and we're only seeing a small portion of those individuals that she believes is like they have to basically say, I don't know how to get HIV care. We think that there are individuals that are just not regular with their HIV care on the outside in the jail when they're not coming into jail, but we're only getting a small portion of that. So our reach would be, the denominator for a reach would be all people who are HIV infected. And the numerator would be the number of people who are identified with HIV, and of those, the number that have problems in getting care. And let's say that's 50% of the individuals. So, and then we may only get, let's say we have 50% of individuals are identified, so that would be like 50 people out of the 100 that are infected at any time. And if and 50% of those may be having problems, so that's 25, but we're only getting maybe 1 or 2 referrals a week. So we would be having 2 out of 100, 2 out of 50 perhaps is our reach then.
Yeah, it's tough. And this is where I would say it's the biggest challenge to both measure and to actually make a big dent. So the way you are assessing it sounds accurate. Now it sounds like for you it's a rolling reach effectively, because people could stay for a long period of time incarcerated. So there's a question about how quickly you might want to reach people. Well, we don't necessarily need to get into it, but yeah, effectively, it's like if it's really everybody who's HIV positive, how many people were offered treatment and how many initiated treatment, that sounds like that's how you would look at reach. And if it's low, it just tells you that we need another strategy to get this provider to refer people over. Like, what is it that we can do to get her to hook people out of this situation and kind of get them into your care, which is tricky.
And then we had another situation with a TB protocol where, and this is in a low resource country, and we had universal screening of everyone with chest X-ray as the diagnostic tool. So we had a pretty good idea who had abnormal lungs fields and were likely to have TB. And we had a digital version of direct observed therapy that permitted DOT and treatment in provincial prisons. And that was essentially the only way we could get people treated. We would have correctional officers put people in front of a tablet that would project to the healthcare entity in the main capital, and they could watch direct observed therapy. And without that program, there was no access to care. And we've been faulted in saying we couldn't say reach was the number of people who came aboard in that system, because that was the only way to get care at all. And I've never quite understood why that couldn't be considered reach. If your method, it's that opposed to nothing, or maybe every now and then there'd be somebody that they'd at least try to do non-observed therapy, but it essentially, our program was the only way to get treatment. And people said we couldn't use that for REACH.
Okay, let me circle back to you because that doesn't seem to make a lot of sense to me on the front end. So
Okay.
I'm gonna wanna, I'll definitely
Move
loop back
on,
with
move
you.
on. Okay,
Yeah,
no
no,
problem.
not that I don't want, but I actually want to really understand that because it seems maybe like it's not making a lot of sense.
Yeah.
Okay, so if you are doing your pilot, the other types of data that you would like to collect, and so also thinking about this on the front end about the data you want, are how representative of the patients who were reached of the population that's being targeted. So let's just say you are only reaching women and you're not reaching men, or you're only reaching young people and not old people, or you're only reaching, it doesn't matter. The point being is that you want to know how representative your patients are of the population. You will only know that if you have background data on all the individuals, which is tricky and sometimes you do not have. But you do your best to figure out of the population that you're intending to reach, are you able to collect sort of, are you getting the same SES? Are you getting the same gender balance? What does that look like compared to the population you're hoping to reach? Are you excluding any patients from receiving the intervention? That's not super common. Well, it depends. Sort of that can happen depending on the intervention you're talking about. And if you are excluding people, you want to make sure that you collect the reasons for why you're doing that. And it's quite nice if you have a multi-site study going on to look at whether REACH is consistent across sites or implementers, because you may see some people do a great job of reaching individuals, or some sites do a great job and others don't. And then when you actually do the analysis, if you just kind of lump them all together, something may look like it doesn't work, whereas it does in some places and doesn't in others. Next slide. So again, the E for in REAIM is either efficacy or effectiveness, usually effectiveness in these trials. So these are some of the different types of measures that you can look at. You can look at acceptability and appropriateness of the intervention or the strategy. So remember, the intervention is something like PrEP, so the actual medication. Your strategy could be having a CHW, screen people for that, or task shifting, or whatever your strategy looks like. So you would want to, ideally, with healthcare providers, assess whether they think the intervention and the strategy would be acceptable and appropriate for the population that they're working with. You also want to look at how well the intervention works. So that's when you're sort of looking at our clinical outcomes, which I don't feel that we need to cover here. I feel like everyone's taken enough epidemiology classes to probably sink a ship at this point. But you want to try to figure out, are people living longer? Are they staying HIV negative longer? Are their CD4 counts higher? Viral loads lower? Whatever that looks like at the patient level is what you would want to be assessing. Next slide. Adoption. How many people are only doing a pilot in a single site? One hand. 2, 3. Okay. Yeah, so this is a common one where people will say, yeah, we had 100% adoption. Our site that we decided to work with to pilot something, it's great, they did it. And in that case, I feel like adoption can be less useful than in other situations. But let's just imagine you're doing implementation preparation. So you haven't implemented anything yet, but you're trying to figure out, will people be interested in this strategy and in this intervention that you're proposing? You would be essentially, I don't know why it's required in the pre, but not in the pilot phase, but in both cases, I think it would be really important to measure at the site level whether the intervention is considered appropriate, acceptable, and feasible. And again, they are the Weiner measures, the AIM, IAM, and FIM, which when I put this document into the chat, you'll be able to access because there's like a tab that shows what those look like. And then again, if you have a strategy where you're going to do task shifting, or you're going to be doing some additional support at the provider level. Maybe you're changing your electronic medical system, where people will get pop-ups, whatever that's going to look like. You want to make sure that that strategy itself is also acceptable, it's appropriate, and it's feasible in that context. And then a lot of, you'll see here in the preparation phase, a lot of these are not necessary. But once you start piloting, it's sort of nice to look at whether the potential sites, sort of the potential sites in your target health system or community, are they eligible to provide the intervention? So it's, some sites may or may not have the capacity, or they may or not have the necessary funding to provide the intervention that you're proposing. So you would want to figure out who's eligible. Then you would want to see how many sites did you approach to provide the intervention. So if you only do your project in one site, but you approached 27,000 before you got to one site that said yes, you may be like, Carolyn, my adoption is 100%. And I'm going to say, actually, it's not. It's 1 out of 27,000 because you approached a whole bunch of other ones. So you want to make sure that adoption is you're measuring it honestly as much as possible. So the number of sites that agree to provide the intervention, and then importantly, the number of sites that actually begin providing the intervention. And not only that they do it, that it doesn't take them, a year to actually implement it. They're not dragging their feet, and that they're relatively enthusiastic about doing it. And then if your sites, let's say you do have like a clustered trial, you would want to look at whether the sites who are agreeing and actually begin to implement the strategy and the intervention, whether those are different in any kind of systematic way from the sites that do not agree or do not actually begin to provide the intervention. All of this may seem like it's a lot, especially if you have access to potentially dozens and dozens or even hundreds of sites. But the goal really is to figure out, are you essentially cherry picking the work that you're able to do at some sites? And that's going to happen. No one's going to fault you for working with people who are enthusiastic to work with you, but you also have to be honest. Sarah, I see you have a hand up. Maybe. Sarah, do you have a question?
Sorry, that was from before when you asked us to raise our hand, and I thought I'm also not a fan of Teams, and I thought I had put it down. Sorry about that.
No worries. No, I probably should have noticed it. Next time we're using Zoom when we do this. All right.
That would be great.
Adoption at the level of the implementer. Again, so same type of things. We're looking at, all of this is the same. Okay, if you could scroll one next slide. Implementation. This one, I would say, gets to be the busiest or biggest, in addition to effectiveness, of the aims that I tend to see people proposing in implementation science projects. So implementation is effectively, how well are you able to deliver this intervention and this strategy? Do you do it well with fidelity? Are you able to do it and it doesn't cost so much that it's not sustainable? And then are you able to sort of consistently implement this across different healthcare settings or different providers so that this is something that can be maintained for a long period of time? So obviously in the preparation phase, if you have a preparation grant, you're in the clear right now. If you're doing a pilot phase, you got a lot of things that are required, and the same with bringing it to scale. So ideally, you would know how quickly the implementation is being delivered, intervention is being delivered to eligible patients, but very importantly is sort of fidelity measures. So how close is the intervention delivered as designed? So if prep is supposed to be provided on day 2 after a specific measure is taking, this is totally not true, but let's just say you find out that somebody is at risk and they're eligible for prep. How quickly are you able to deliver that intervention? Is it being delivered as designed? Are you doing all of the appropriate counseling for that particular intervention? Is it being done with quality? So you could have somebody sitting in the room with somebody who's delivering a particular intervention with like a checklist. did they say this? Did they say this? Did they tell people about that? And you'll be able to understand, is it being done with fidelity? Sometimes interventions, particularly behavioral interventions, do need to be adapted, and that's fine, but there's a whole process for doing adaptations. And so did you go through that process using, say, FRAME, for example, and assessing what adaptations needed to be made, and when you did them, and who made the decision, and sort of what was the final intervention? What did it look like? And not only does the intervention sometimes need to be adapted, sometimes the strategy will need to be adapted. So if your strategy isn't one that you already know what it should look like, you would, or sort of, it needs to be adapted, you would want to make sure you document all of those as well. You would want to make sure that the strategy is being delivered with quality and is being done with fidelity. So kind of tackling all of this can seem like a lot, and you might be like, am I just like a fidelity measurer? And I will say you're not, but you do need to find ways to assess fidelity to both the intervention and the strategy, particularly when piloting it. And then again, when bringing it to scale, because if any of these things fall off, and when you look at your effectiveness and you say, hey, ISKI, this, or, to the NIH who funded this particular intervention doesn't work. They want to know, does the intervention not work, or was it not delivered properly, or did your strategy fall apart? Because if your strategy fell apart, maybe we need to change the strategy. We got to figure out what went wrong. And this is really the what went wrong cluster of metrics, or what went right, because a lot of people don't do things. Or I think delivering something with fidelity is one of our greatest challenges. Next slide. So one of our last metrics is maintenance, and I believe, I can't remember, was it Russell? Someone said that one of the things with maintenance is you sort of look at it over time, and particularly after your project has ended. So now if you're in your implementation phase, again, or your sort of preparation phase, again, you are sitting pretty here. But if you're piloting, and particularly if you're bringing something to scale, then we would suggest you looking at some measures of maintenance or sustainability. So whether the sites continue to deliver the intervention after usually at least 6 months. Now, this is very hard to measure when you guys have a 1-year grant, and I don't think anybody is going to sit there and chastise you if you're like, hey, I just got this up and running in the no cost extension phase. There's no way I can really look at maintenance. You probably won't be able to look at whether the site is continuing to deliver the intervention or whether the strategy is sustainable. But what you can do is something like do interviews with that health system or with providers who are supposed to continue delivering this, and ask them, hey, is this going to be something that you feel like you could sustain? Is this something what are some of the barriers to sustaining? What are some of the other things that we may need to look at? So, like, ideally, you would be looking at this from a quantitative perspective, but if you can't, then doing some qualitative work could be very useful here. At the implementer level, you could look at whether the intervention, delivery, and strategy are being sustained over time. Again, I don't really think that this is ever going to happen in a pilot phase, but when you're bringing this to scale, if you're putting a lot of money into implementing something, you can pause putting your money and the additional support the project is giving for at least 6 months. And then you would look at whether the intervention is going to be delivered and be sustained over time, and whether sort of the quality is sustained over time, and look at any adaptations that are made once you stop providing support. So were you providing so much of a crutch that they need to do something to make some changes? And it's not necessarily going to be a bad thing, but documenting that process is actually really important. And you can look at patient level outcomes as well, whether the intervention effects are being sustained over time. Next slide. Excuse me. So by the numbers, essentially you're like, man, this is a lot of measures. I assume there's a lot of people that are like, I didn't start measuring these things on the front end, so I'm going to really be in difficulties. But essentially 71 different things to look at, whether in the implementation preparation phase, the piloting, or the bringing to scale phase. There's certainly more required in the piloting and bringing to scale than in the preparation, but nevertheless, these are things that you want to be looking at, and ideally you kind of started thinking about before you were implementing. So we're going to do this lecture with people as they come into the project this coming year. But what we'll do is we'll work with you to make sure we can get as much as possible for so that you can report as much as possible to the NIH this year. And next slide. Okay, so next we're going to actually practice using the crosswalk, and I was hoping that somebody, and actually, April, you can stop sharing, and hopefully I can share this since it's not in presentation mode. Is there anybody who feels comfortable walking through some of these different tabs with your project in mind? I'm also happy to pick people.
So
Go ahead.
we are having a lot of issues with our particular pilot right now. There's a chance that things will start humming again, but we've had problems with enough referrals. We've had problems with one of a very essential staff member leaving, one of the people implementing with our peer navigator.
Mm-hmm.
If you don't have any one to volunteer, I do have a re-aim project, a pilot project that was dealing with tuberculosis that I would be happy to use that as an example.
Well, I'll go with a different person for each tab. So do you want to start with acceptability appropriate? Can you see the slides, by the way?
Yeah.
Okay, cool. Well, so for your project, because some of this you may have actually looked at this before you started, but do you want to tell us really quick again what your interview? Oh yeah, so it's treatment.
Our HIV
Yeah.
project.
Yes.
Yeah, so we are trying to have individuals who are going through the jail. There was supposed to be universal testing for HIV, opt out, and there would be a funneling of people who are infected into care where there would be a vigorous referral program for case management. And if people test negative and are discovered to have high risk for HIV, that they would be referred to the case manager for referral to PrEP to start after release.
Okay. So with that in mind, stuff like acceptability, appropriateness, and feasibility of delivering that, is that something that you measured in your project?
We did not have a measure of that, but people are walking with their feet. So basically we are having just the medical vendor, the private company is just refusing to cooperate with this, despite the sheriff saying to do it.
Okay,
So we've done it before when there was a different vendor there. So we know for staff it's been acceptable and appropriate and feasible. But with the current configuration, all of a sudden we've lost this acceptability, appropriateness, and feasibility.
Okay. Yeah, it's
so
tricky,
as
right?
far as the clinical intervention, there's been I mean, this was a surprise that this company would be so belligerent.
Okay. So like you almost had you've done this before, so you sort of assumed based on previous data, this would be acceptable, it would be appropriate and feasible, and then it's kind of just blown up a little bit.
Right.
Okay. And so when you're filling this out to the NIH, this is where it's like, ideally, it's like, well, we've had conversations with providers, we've had conversations with the sheriff, we've had conversations like with whoever it is that you have worked with in order to capture some of this stuff. And so you want to get a sense of whom you talked to, like whether it was qualitative or quantitative, whether you measured it. In that case, it doesn't sound like you did, and then what you found. So they want like, whether it's quantitative, like point estimates, like if, let's just say you measured something like fidelity on a 1 to 4 scale, you would say that our mean fidelity score was 3.6 among all of our providers. And if you didn't have something like that, then you would have some qualitative findings with some of the themes that people talked about a lot in their interviews.
Right. So we have, I mean, and the issue with us is that it's over time too. So when this was done before, we actually had the staff that's still there were so enthused about this. They were writing the articles with us. They were going to conferences with us. There was an embrace. And now we've got this private company coming in that's under investigation by the Department of Justice for lack of care. And that they're being told, like, don't do this, don't test people. We won't let them. Yeah. So
Okay.
basically they're saying just do not allow people to get access to HIV care. And DOJ's coming in. And so there's a very good chance that like this could all be reversed in a day when just by the DOJ saying this is unconstitutional. So it's this kind of like, it's a weird situation that I know could be reversed in a minute.
Okay. Well, then I think Russell said he's got some pretty good slides that look a lot like acceptability. And Russell, do you want to talk about the questions that you asked?
Sure. So our thing is the implementation of a status neutral community health worker program in community-based organizations. And it's a multi-site project, and there are 5 EHE jurisdictions that are involved in the project. And so for acceptability, it's more of an exploration, exploratory project right now. So
that's fine.
So we have six things to measure based.
Well done, my friend. Well done.
Yeah, but we might pay for this because we still have to pilot some strategies, right? So so one, I think the first one around acceptability. Now I'm looking for my chat, what I put in the chat.
Yeah, to what extent do you?
Yeah, so so the first part is we're interviewing, staff in community-based organizations. So there's a short survey that they complete prior to the interview. So we're asking them, their thoughts around to what extent do they agree with the following? This type of project is appealing to them. So I think that's acceptability. And then there's a question around it's a good fit for their organization. So I think that's more appropriateness. And then the last one is around can this be done within a specific period of time? So I think that's also aligned with feasibility.
Yeah. Okay. Why did you pick these 3 questions, just out of curiosity?
Well, I think we realized we had to include questions around acceptability, appropriateness, and feasibility. So that's why.
Okay, that's fair. That's fine.
Yep.
Okay. So you've got some of this, and you said you've got qualitative as well. Elvin.
Yeah, so we will have some qualitative data.
Excellent.
Yeah. So we're wrapping up the interviews, and we will have some qualitative data that, looks at barriers and facilitators and other issues of interest. And our goal is to actually end up ranking implementation strategies.
Oh, fabulous. Okay.
So we would love some sample surveys around how you actually craft questions for people to rank that is not a DCE type survey, but just like give them some strategies to choose from, and then they just select the ones that they like.
Okay, yeah, I like that. I know someone that's done that, and Elvin looks like he's got his hand up, so we can definitely chat with you about that. Elvin, do you want to contribute?
Sure. I had a couple of thoughts, but Carolyn, I joined late, and feel free to gong me, or if I'm
You're not
kind of
going to
getting this
forget
off
that one,
track.
are you?
What?
The Gong Show comment.
No, I use that a lot because I'm clearly a candidate for being gonged frequently. So, but w- one thought, and then I wanted to just a couple of quick thoughts. So for me, like some of the concepts in Reaim, a lot of times there's some discrepancy between whether or not people are thinking about, for example, reach in your sort of source population versus in your target population, right? And like to me, the inferences that you would make scientifically should be focused on like the universe of either clinics or people or healthcare workers or patients that you ultimately seek to infer in, which could be quite different from your the source population for your study, whether that's a population of healthcare workers or facilities. If that makes any sense.
Mhm.
And just to kind of like build off of some of the comments that I heard earlier about reach, like, you may want to infer in like, say, all HIV clinics, but you may have like a very small restricted sample to that you have access in. But reach ultimately isn't necessarily about the fraction of your sort of accessible source population of clinics, but rather like I think ultimately where you would want to infer. So that's maybe my 2 cents on things like reach and adoption and things like that. Now, whether or not you can infer about that wider setting is an open question, but you can often position yourself to learn something about that wider setting, even if even if the population that you choose to or that you have access to isn't fully and totally representative of it.
Before you continue, I've just pulled up our reach slide. Do you want to give an example of where you had access to a particular subpopulation and then how you would potentially look at filling this type of metric out?
I am on
You're
my
on the
phone,
phone.
so
Forget it then.
I can't quite see, but um I remember this matrix and I can come back to it a little bit,
Yeah,
but
absolutely.
I don't know if my comments fully kind of like fit with this, but we can maybe talk about that.
Yeah.
But if folks want, I can follow up on email and give like an example of that. But I think just to say that like ultimately at the end of the day, right, you will want to be clear about like the universe in which what you find applies. And I think of that as sort of starting with the kind of like target setting or population, and then working your way from that to like your source and then your study sample. I think that's possibly one way of thinking of it. I mean, like Carolyn mentioned, sometimes people have studies where they say, okay, we have like really great reach, but it's reach into a very restricted sample, and everybody would agree that that's not the universe in which you would want your findings to apply to.
Yeah, so I just pulled up in the reach, and essentially like what we're talking about here is like your public health denominator, so like your true population that you're hoping to reach in general, not just like the patients that were eligible uh in like your study denominator, I guess, versus like the public health denominator. And a lot of people have trouble capturing how am I going to get the information for the public health denominator? But obviously that's the goal. That should be the goal. is to capture sort of like how well are you actually going to be able to reach the population of interest.
Yeah, and not being like totally hostage to standard like sort of a probabilistic like sample with like, you know, statistics about it isn't the only way to infer about like a public health population. So it, and then I was gonna say the the issue of feasibility is similar in the sense that like there is feasibility of like the study, right? So you're seeking to do something and there are considerations around the feasibility of the study. I guess I think of those as being distinct from the feasibility of the strategy or the feasibility of the intervention, depending on what you're talking about. But again, there's like reality, and then there's a layer on top of reality that we create with like study designs and measurements and things like that. And feasibility in each of those domains, I think, it's good to keep in mind as being sort of like separate concepts, at least in my way of thinking about it. And then lastly, you were talking about ranking without like a DCE. One alternative is, I don't know if you've come across like best worst scaling, which is quite, it's like it's a sort of a simplified version, but it allows you to sort of calculate relative utilities at the end of it, which helps, with prioritization and trade-offs and things like that, which, standard ranking exercises don't get you. But a best worst scaling is like, let's say you come up with, 20 strategies. You would offer your respondents like maybe, a group of 3, 4, or 5 and ask them to pick the best and the worst, the one that they're most interested in, the least interested. And then you would repeat that like many times. So the choice task is simpler than it is in a DCE. But then you'll get a little bit more than a raw ranking as your output. So just a thought there. But again, Carolyn, I'm handing it back over to you. And yeah.
Well, just because I know we're running on time. I mean, we booked till 3:30, but a lot of people couldn't stay. So in terms of when to measure things like acceptability and appropriateness and feasibility, I feel like there's been a lot of discussions about that, and sort of Elvin and Ima and I certainly have had these discussions. Do you look at acceptability of an intervention before you do potentially some training? Do you look at it after? Do you look at the appropriateness on like obviously you'd want to do some of these things on the very, very front end, but somebody may say something is feasible before they've tried it, and then they try it and they're like, actually, this isn't feasible. And so figuring out when you want to capture data on specifically some of the strategies um, might be something to really consider, that you don't just have to measure this stuff once. A lot of things you want to get certainly before you really begin, because if something isn't acceptable at all or appropriate at all, feasible at all, you better figure that out on the front end. But you may run into roadblocks along the way, where something that you thought was feasible actually becomes clear that it isn't, and that some adaptation needs to be done. So kind of figuring out when you want to do those assessments is important. And I don't know, Elvin, if you have additional thoughts, because we talked about that a couple of weeks ago as well.
Yeah, I mean, I think if you end up like delving into the preference literature, I think, there are kind of like pluses or minuses. I think if you ask people about like acceptability of something they haven't experienced before, it mimics like the experience that people have when they're first confronted with something that they haven't had a lot of experience with. But if you are able to assess sort of acceptability or other constructs, like in people who've had those experiences, it tells you something different. And, depending on sort of what you want to learn, I think one or either is maybe appropriate. I mean, one other area of like sort of research is the idea that, acceptability and preferences are also malleable, and people can develop like interventions or strategies to kind of like inform or change how people conceive of certain sort of interventions, whether it's through social proof or like social norms or other mechanisms. I think preferences are important to assess, even if they're not, but to say, yeah, they can also be shaped. I can't remember. There's a nice paper about that. There's a group at RTI that's published quite a bit on preferences in HIV prevention, and they have a nice paper about kind of how preferences can be shaped and reshaped.
So I think we've had a lot of people drop off. So I'll run through because I don't know, Sarah, are you guys at the point where you are piloting the project that you're doing?
So for our project, we're developing a video, and then we're evaluating the video. And
Okay.
so we're at the point where we've just done focus groups and interviews to inform video development, and we're in the early stages of developing the video.
Okay.
So I think the measures would be coming more at the evaluation phase, which we haven't started.
Okay, that's fine. So once, sort of as I mentioned in the earlier lecture, but just to kind of go over this again for when people are watching this video, with adoption, you want to get a sense of whether your sites, whether somebody actually adopted it, sorry, I should start again. How many potential sites have adopted the intervention, which means how many did you approach? How many agreed to provide the intervention? How many actually did provide the intervention? And are those sites representative of all the sites that you could have worked with? So did you pick the richest ones that are in the richest areas, who have access to the greatest number of staff? And therefore, yeah, adoption looks fabulous because you picked the 12, most capacitated. Or were you able to sort of look at all of the different sites that could potentially be worked with, in order to make sure that whatever strategy you develop, it could be used in a greater number of locations? It may be that you need different strategies depending on the different types of facilities that you're working with, and that's fine. But just make sure that you're very clear about why you picked the sites that you did, who said no, who you approached, and who you may have excluded in the same way that we can look at, like maybe with REACH. So in addition to looking at it at the site level, you can look at it also at the implementer level. If an implementer has the ability to sort of say yes or no within the context of that facility. So in the same way as you would say how many sites actually adopted, how many were approached, how many agreed, how many actually began, you can look at it at the level of the implementer as well. In terms of implementation, the focus here is usually on the site and the implementer. So whether the intervention or the strategy is being delivered as intended. So whether it's complete, whether it's done with quality, and what adaptations are being made, and how did you document those adaptations? Those are usually the things that we tend to see in grants. We also look a lot at costs of the intervention, and cost per the amount, like sort of cost effectiveness type work can be done. You'll see that a lot in aim 3 of a grant. And then how consistent is implementation across sites or implementers or strategies? We've talked a lot about REACH. I feel like effectiveness is something that most everybody knows about. So certainly you just know if you're piloting or you're doing a clinical trial that you're going to have to document these outcomes and send them to the NIH. And then lastly, maintenance, which my guess is nobody will do in this project because it's a 1-year pilot. So you're trying to look at, is the delivery of the intervention and strategy being sustained over time? Again, how did you measure it? At what point did you measure it? At least 6 months or 12 months after you've started? Is the fidelity continuing to be as high as when you first started or when you were providing additional support? And are the intervention effects being sustained over time? Ideally, that you will not see a drop off after the trial has ended. So most of you guys are gone, but hopefully people can come back to the video. Certainly as you get further along in your projects, we're here to sort of walk through this with you. If you don't collect the data, obviously it's not possible to fill it out. So thinking about on the front end of things, what are some pieces of data that might be important to collect, and how do you want to do that? And your mentor is the best person to sort of work with you to sort of figure out how the best way is to do that. So for the 2 people we have left, do you guys have any questions before we wrap it up? Anne or Sarah? No, you guys good?
No, this was very comprehensive. Thank you.
Great. All right, and Anne, it sounds like we'll need to circle back with April, and we could potentially talk about your reach question. Okay, fabulous. Well, thanks everybody for joining. I really appreciate it.
Thank you. This was good.
Excellent.
Thanks. Bye.
Thanks. Bye.